Our next speaker is Associate Professor Louise Emmett, and she's a theranostics and nuclear medicine for the imaging and treatment of prostate cancer speaker. She's involved here in nuclear medicine as a physician at St Vincent's Hospital. She's also a researcher at the University of New South Wales, and she's really involved in multidisciplinary research into imaging and therapy for prostate cancer. So please make her welcome as she comes on stage.
Right, well, first of all, thank you so much to the PCFA for asking me to speak to you today. And Julie's given me the hard word and told me I have to speak slowly, but I'm going to try. But actually, it's a really exciting field that we're in, and it's just changed so much. It's kind of hard to speak slowly, but I will try. So basically, I am a nuclear medicine physician, and my specialty has changed dramatically in the last 5 years, and it's what we're doing in prostate cancer has, I believe, transformed the treatment and the therapy of prostate cancer, both for imaging and diagnosis. And this, in fact, is one of the patients who was on one of my trials. This is what we used to do, and we still do a little bit. It's a bone scan, and this is what we call a PSMA PET scan. So this is the same patient. It was done 2 days apart. So this is the old technology, the bone scan, and what we can see on the new technology is we can see the sites of disease, and this is metastatic prostate cancer in a man who's got extensive bone disease who was being imaged for one of our trials. The fantastic thing is we can see where the cancer is, whether it's in bones, in lymph node, in the liver, or in the prostate. And we can do that all with one scan. It also gives us information on how aggressive that scan is, and it tells us what kind of treatment would be best for that patient. In the old technology, when you look at it, even for a nuclear medicine physician, it's pretty hard to see where the abnormalities are. You certainly can't quantify it. I can't see what's happening in the lymph nodes. I can't see what's happening elsewhere on the body. And I can't tell anything about that cancer as to how aggressive it is or not. So we've moved a long way in just a few years. And so this is what we're actually measuring. This is on the prostate cancer cell surface. They're like sticks that sit on the prostate cancer cell surface, and there's these very, very clever peptides that have been developed in Germany and the States. They're little proteins that have been developed to bind very tightly to these receptors. So we inject them, and then they bind to these receptors. Those little peptides then fall into the cancer cell, and depending on what we've labelled them with, whether a PET tracer agent or a therapy agent, they go directly to the cancer cell, and they concentrate there. So when we get the pictures, we can see all the cancer cells, or if we're treating, it actually treats all the cancer cells without too much effect in the rest of the body. So it's highly effective, targeted therapy and imaging that we're doing. So this is a transmembrane glycoprotein, which is perfect. And one of the amazing things about this receptor is it's only seen on prostate cancer cells. So when we inject it, we know very clearly that it's a prostate cancer cell that we're looking at, that it's metastatic prostate cancer, or whether the cancer has spread or not. In fact, it's been a really rapid journey. So this is from 2012. And it's actually the first publication I can find, and it's in a mouse. And after that, it got introduced into clinical practice in Germany, and we introduced it in clinical practice for imaging in Australia in 2014 at a few sites, and then it just took off in a whole lot of different ways. And what it actually does in the cell is really, really important. When we first started doing it, we thought, oh, this is great. We can actually see the cancer. But we didn't know what the receptor was actually doing on the prostate cancer cell. And that's actually been very important in us determining how we can best use this technology. And what we know now is that prostate-specific membrane antigen is doing nothing good on the prostate cancer cell. What it is it's a growth mechanism. It's a way that the cancer actually develops another food source when it has its androgen receptor cut off. And that's something that we're actually incorporating into a lot of the new trials that we're doing now. So where do we start? So when men have a radical prostatectomy, about a third of men won't get complete cure from a radical prostatectomy, and the PSA will start to rise again. So in the past, the treatment has been that in the vast majority of those men, they will go for what we call salvage radiotherapy. So they'll have radiotherapy to the prostate bed to try and mop up any cells that might still be there. And that's great for about half of those men. But half of those men actually have radiotherapy to the fossa or the surgical bed and don't get any benefit from it, but get some of the side effects from it. So when we first started offering this PSMA PET agent, it was exactly that group of patient that everyone sent. The radiation oncologist sent, the urologist sent, because they wanted to know where the cancer was. And in fact, this is the very first patient that we imaged at St Vincent's, and we started with a prospective trial. And these patients very kindly agreed to have 2 different types of PET scans within 2 weeks of each other, so we could tell whether the PSMA PET was actually better than what we were doing before, which was a scan called choline. And so this here is the choline scan, and this is the PSMA PET scan. And if you look at the arrow here, what you can see is this little golden yellow dot. So this was done within a week of each other, these 2 scans. And on our old technology, we couldn't see that lymph node, which is what's here. But on the PSMA PET scan, we could see it very, very clearly. And in fact, that patient then went for surgery. That lymph node was removed, and we found it was cancer. And it was a hugely exciting moment, because that PSA was only 0.2. We could never detect where the cancer had gone with the PSA so low before. And I was like, wow, we've got this, we've cured this, we know what to do now, we can track the cancer, therefore we can treat it much more effectively. But nothing's ever that simple. 6 months later, this patient turned up again, and the PSA hadn't responded to the surgery as well as we would have hoped, and now we know that that doesn't work particularly well. And when we re-imaged them, we found 2 more lymph nodes were involved with the cancer, directly above where the previous lymph node surgery had happened. So there's a very clever urologist in Melbourne who says that we poker-metted that person. We saw where the cancer was, which we'd never been able to do before. We treated that particular bit of cancer, but we hadn't thought about the bigger picture. So in fact, we hadn't really helped that person. We thought we were, but we hadn't. And that really introduced a whole line of research for me in terms of how we can use this amazing technology to better treat patients and appropriately treat patients so that we do it very well. So in fact, it comes down to us thinking very, very carefully. It's not just about what's bright, what we can see on the scan. It also comes down to what we can't see. So this is a study that we've been doing for the last 3 years. We've just had accepted for publication, and we've done a series of publications on this. And what we've done is we've taken these men who had this initial scan after radical prostatectomy where their PSA was rising, and we've followed them. So we looked at what treatment they had, whether or not they went on hormone therapy, whether or not they had radiation treatment, and whether or not they had a good response to that. Were they cured at 3 years? Did it actually help the patient? So we had 260 patients we've been following who had a rising PSA, and we followed them now out to 38 months as a median, and we looked to see exactly what happened to these men. And what we found was really, really interesting. We found that if you have a positive scan, as in if we find anything on the scan that shows you've got a lymph node or if you've got disease more distantly, you didn't do particularly well with radiotherapy, even if they gave you more radiotherapy and even if they added hormones to it, the PSA often started to rise again. But what was fantastic was that the negative scans, so people who did not have any abnormality on the scan at all, if those patients just got conventional treatment, 86% of them had a complete freedom from progression at 3 years, compared to 50% to what we would expect from all patients. So we can actually triage patients. We can say, look, you should really go and have salvage radiotherapy. And these are the curves where we look to see whether we can differentiate how patients are going over the 3 years. And you can just see from here, these are the patients who had a negative scan or disease just confined to the fossa, and these are the guys who had disease elsewhere within the body. And this is what we call a Kaplan-Meier curve, and it just shows the number of patients who have progressed over time. So patients who have a negative scan do really, really well with the kind of treatment that we've got easily available. But what was also interesting was that if you had a negative scan, you were much less likely to be offered this treatment. Most of the time, if you had a negative scan, they said, oh, look, you know, it's negative. Let's just watch it for a while. We're not going to treat because we don't know where it is. And what we found was if you didn't treat, most of those patients actually progressed over time. But if they couldn't see it, but they still elected to treat, patients did really, really well. So what we've really discovered is that it's very, very useful to know where the disease is with these new tracer agents, but we also have to know how best to treat patients, and we also have to know how to recommend treatment based on the results of these scans. And at the moment and up till now, we've been guessing. So men with biochemical failure after radical prostatectomy, or with a rising PSA after they have a radical prostatectomy, who have a negative PSMA PET scan, are the men who are most likely to have really, really good response to treatment, but they were also the least likely to be offered that treatment. So that's education of clinicians. That's education of radiation oncologists and urologists that people like me have to do. And we have to publish these papers so that we know best how to treat these patients. So we're now designing trials around this, and this is we're going to call DIPPER, and it's something that PCFA does fantastically. It offers availability of grant funds in order for us to be able to put in applications for trials that we think are going to change practice. And we've got one of those coming up through ANZUP in a couple of weeks, and I'm definitely putting this in because I really want to know whether we can de-intensify treatment safely in men with negative scans, whether everyone have to have salvage phosphoradiotherapy, or if there's a group of men who will do really well if we don't do anything at all. Therapy and diagnostics. So it's this new word that's been adopted around the world by my specialty, and it's called theranostics. And what is it? So what it is these super cool new peptides that have been developed that bind very tightly to receptors on different cancers. In this case, it's PSMA. And what we can do, it's a clip-unclip system. So I can take this peptide and I can clip on a PET agent and get a picture. Or I can take this peptide, same peptide, and I can clip on a therapy agent, a nuclear arsenal, and I can actually kill that prostate cancer cell if we want to. And that's certainly what we've been doing in the last couple of years. So we actually use the imaging very, very intensely to try and identify the patients who will do best with this targeted PSMA therapy. So this is one of the patients on our first trial, and what we do is we do 2 different PET scans. What we've got up here is the PSMA PET scan, and as you can see, this man had failed multiple lines of chemotherapy, and all this black stuff here is extensive disease in his bones. That's prostate cancer in his bones. Then we do another PET scan, which is called FDG PET, because sometimes you get some cancer cells that don't express the PSMA receptor, and they won't respond to this treatment. So we need to make sure that all sites are expressing the PSMA receptor very nicely, and that helps predict whether or not a patient's going to respond to treatment. So this patient had extensive bone metastases. He had failed 2 lines of chemotherapy, and his PSA was very, very high at the time that he turned up to our department with significant bone pain with a PSA at 95 nanograms per mil. So what these images are, they're actually lutetium PSMA. So we inject lutetium PSMA, it concentrates at all the sites of cancer, and then it gives off what we call a beta emitter, and it kills the cancer cell. A little bit of it is given off as a gamma wave, which means we can take a picture. So these are all the sites that this patient is going to have treatment response. And we can see exactly where the cancer is. And if you look at this one, this is after 1 injection. You can see there's a lot of disease here that you can't see here. And that's all the cells that have died in the intervening 6 weeks. So we know he's having a good response because we can't see them anymore, and because the PSA went from 95 down to 8 over 6 weeks. So it can be a highly effective treatment if we choose the patients carefully. But it doesn't always work. So this is another one of the patients from exactly the same trial, and we see here this is his PSMA PET, really nice bright disease there, not very much at all on his FDG PET. So I would have said, yep, this patient's going to have a fantastic response to treatment. But you know what? Unlike the other patient, every time we injected him, he had all of these spots. So first dose, second dose, third dose. No response to that treatment at all. We're just not making inroads. And why is that? What's different between the first patient and the third patient? And these are all questions we have to answer, and we have to answer them fast so we know who we should be offering this treatment and who we shouldn't, and what we should be combining it with. My thought is that this patient has a really super hyped up DNA repair mechanism. So the minute they get a damage in their DNA, they just repair it really, really fast. And so my attempt to damage the DNA and kill the cells using this radiation just aren't working in this particular patient. So what can we do about that? So this is my first trial, and one of the important things from this trial is that, I'm going to go straight on to the next one. In fact, there were two trials that came up pretty well at the same time. The first one was at Peter MacCallum. Oops, sorry, go back. The first one was at Peter MacCallum, and what this is a waterfall plot, and it shows the patients who have responded to treatment down here and the patients who didn't respond to treatment up here. And in my trial, only 36% of the patients actually had a significant treatment response, not particularly good. While at Peter MacCallum, 56% of patients had a significant treatment response. And you could say, I'm just worse at it, and they're better at Peter MacCallum. But it's not actually, well, I mean, it might be the case. No, it's not actually the case. In fact, the case is that I didn't choose the patients correctly. I'd never done this before, and when I first started, the first 4 patients that I ejected just didn't have bright enough disease on the imaging. And then I got better. And after that, everyone responded. So it's a learning curve for us. And how bright the disease is very, very important in terms of how much of a treatment response their patient actually gets. But sometimes the disease is bright and you still don't get a treatment response. And so we teamed up with Noxopharm to do a second trial, which we're undertaking at the moment, which is a prospective trial where we're looking at combining lutetium PSMA to a radiation sensitizer to try and stop those cells from repairing themselves as fast so we get better cell death and better response. Cool. So if we use combined treatments that are targeted, can we actually get really good treatment response without actually getting too many symptoms in the patients? And I think we can, and I think we've definitely shown that with this trial. And how good are we doing? So this is the interim results that we looked at, that we presented in America in June in the first number of patients. And what we found was I've gone from a 36% of patients actually having a treatment response to 69% of patients having a treatment response. So I've almost doubled the number of patients who've benefited from the treatment. We also increased the time at which they could go before they had any relapse. So we're doing really, really well. And that's because I'm probably choosing the patients better, and we're using combination treatment to try and make the treatments more effective. This is one of the patients from the trial. So this was him at enrolment with a PSA of 160, and you can see all these black dots here. That's all the disease right throughout his bones. He was very unwell when he turned up. Hadn't mown his lawn for 2 years, according to his wife. That was November 2017. And then August 2018, he came off our trial. PSA at that stage had gone right down to 7, and you can see very, very little disease. And so now we're at June 2019. His PSA is lower than it was before, and he emails me every so often asking why his PSA keeps going down. So I don't know. I have no idea. He finished treatment well over a year ago, and what it means is there's lots of things happening that we don't understand with this treatment, and we need to. So we need to do more and more trials, and that's where PCFA is so fantastic. So I have to talk about the therapy trial. So the therapy trial has been a co-partner funded with ANZUP and PCFA. Thanks so much to PCFA for doing that. This is a trial we've been doing, randomised trial comparing chemotherapy to lutetium PSMA around Australia. So there's 11 sites around Australia involved. And what we're doing is we're doing chemotherapy compared to lutetium PSMA, and we've just finished randomisation, and we'll be reading that trial out in June next year at the biggest American meeting. Hugely exciting to see whether we can get a non-toxic targeted treatment that works more effectively than chemotherapy for men with prostate cancer. The other trial that I'm really proud that we can start, and we're just through ethics yesterday, is a Movember PCRA funded grant that we're doing where we're looking again at non-toxic combinations. So how much better can we make these treatments? We know they're effective, but we can make them even more effective by choosing what we team them up with. Instead of looking at sequential treatments, we use treatments together to get better effect. And this is a very complex trial. We're also looking at a lot of imaging to see if we can predict which patients will do best. And there was a question earlier today about liquid biopsies and CTCs. So what we're doing is we're actually match pairing every single PET scan with liquid biopsies so we can see which is best. What biomarkers should we be using to predict who will do best, and what these men should have as next best treatment to get the best opportunity for the best quality of life for the longest time. So this is really what we call precision medicine, getting to the right drug, the right patient at the right time, looking at predicting treatments, sequencing and combining. So from the NZP trial, we're aiming to do a number of things. We're going to be completing a large randomised trial where we're comparing treatments to each other to see which one we should be using. We're going to be getting a lot of information on PSMA PET to see how best to use that in these patient populations. And we're doing a huge amount of translational work trying to figure out what we should be combining next. What should we be doing to get even better treatment responses? And that's a big thank you to the PCFA from my team for all the help.
Thank you so much, Louise. Thank you. Louise, please, just before I go to questions, I want you to help me. What are the 3 key messages, put as simply as possible, we should take from your presentation? One thing I got is that you're using imaging to make the delivery of treatment more precise. Is that one message?
Absolutely. So we're using PET imaging to make the delivery of treatment more precise. Absolutely.
Hand up if you've had a PET scan. So lots but not all. So in a nutshell, what's a PET scan?
So a PET scan is where you take one of these little peptides, you label it to a PET radio tracer that can be detected by our cameras, and you inject it, right? It finds the cancer cell. Often patients will lie down for about an hour. We give that little peptide or that protein plenty of time to find the cancer cell. Everything else goes out in the urine. So by the time we put a patient under the camera in about an hour or 2 hours, we have this beautiful image of exactly where the cancer is.
I had a PET scan 2 weeks ago. I would have described it slightly differently. But they inject you, leave you for an hour, and then they pop you in a tube for about half an hour. That's the nub of it.
Yeah. Okay.
And they get, as I understand it, the most accurate images of all. So one is you're using that wonderful PET scan technology to be more precise.
Yes.
What are the other 2 very simple messages? And then we'll go to questions.
So the other thing is that these little peptides that we can use for therapy as well, and they're targeted therapies, so it just goes to the cancer cell. And we are doing lots of trial. PCFA has been heavily involved in these trials in the last few years to develop that and to figure out how we should best use them.
My one last question, I'll go to them, is I was left with the impression that the selection of the right patient is critical in terms of getting some of those really wonderful results. So what have you learnt so far about who's going to benefit and who won't?
So if you're using these agents on their own as a therapy, then you need very nice, bright disease. And there's a very strong relationship between having a bright scan on PET and having a very good treatment response to PSMA therapy. We've also learned that it works better in later stages of the disease, not very early. And I think that's very important. And what else have we learned? Now I've lost my train of thought.
Well, you're excited, so it means there's hope here for people.
Oh, this is massive. I think that we have transformed the way we image. Look at everyone's had a PET scan in prostate cancer in the last few years. 5 years ago, 7 years ago, I was a nuclear cardiologist, and in prostate cancer, imaging was CT and bone scan. We just introduced one PET agent that was not good. So it's transforming things, and it's very, very positive.
Thank you so much. Questions or comments? Thank you.
Yes, sorry. About the selection, what happens to the poor bastards that don't get selected? Are they just rooted?
So, no, it's a really good question. No, so the answer is I don't think so. So when I first started and went, oh my gosh, these first four patients died, I have to be really careful who I do and do not put on treatment. But then what happened is I actually started giving clinical treatment in the patients who did not get onto trial. So what I said then was, okay, so you're not going to respond to lutetium PSMA alone, but will you respond if I just irradiate those sites that are negative and I treat the others? Or if I put you onto an agent that's going to increase your receptor density, is that going to work? So we've been playing with all sorts of things. So NZP is around a trial that's aiming to increase the receptor density, make it more available to more people and more effective in more people. So I think we've only just begun to scratch the surface. At the moment, we can say from therapy that 28% of men will not be eligible for this treatment. But I've been treating all the men who did not get on, or certainly a significant proportion of them, and getting great responses. So we just need to know more. We need to do more trials, and I certainly think that we'll be addressing that.
Louise, we've got at least 5 questioners in 5 minutes, so we'll do our best.
Yeah. Do you have any information at this stage of your research on survival rates for the people that you have been working with these new treatments? And secondly, how's the funding going for this particular treatment federally?
So in terms of survival, we haven't got a lot of... So overall survival, Michael Hoffman and myself both got about 13 months overall survival in the patients who we were treating with, who were end stage, so post 2 lines of chemotherapy. And certainly post 2 lines of chemotherapy, before the PSA started to rise, we're getting 9 months, even before the PSA starts to rise again, so that's nice long times. But overall survival, there's 2 big trials coming out this year, and we'll get good results from that. We'll know next year, this time next year, ask me again.
I've got 2 men here, and I'll come to that. I'm sorry, I've got to give someone else a go. I'm so sorry.
But I'll talk federally, we're working on it.
She's working on it.
You were saying that the treatment seems to work a lot better in people with very advanced disease. It would just seem logical that actually seeing this as such a targeted treatment, that it would actually also be good for people with earlier stages. Do you have a feeling for why that might be?
Yes, no, absolutely I do. So what happens is, I talked about the role of the cancer, of the receptor in the cell. So it's a proliferative agent, and it upregulates itself when it gets more aggressive or when it gets more advanced. So if you have someone who fails hormones and you repeat the scan, compared to when they started hormones, you've had a tripling in the intensity of the receptor density. So that's why we get good responses at the end. We may still get good responses at the beginning, but we need to know how to combine that. And it's likely that we won't have as good an effect early as we will later. We don't need to be at the very end. So we're just starting NZP, is pre-chemotherapy after hormones, and that's because we're trying to get the receptor to have already upregulated, but not be too far down the track. So we're working on it.
Okay, this question is very similar to the last one. Does the treatment have any use for prostate cancer that's contained entirely within the prostate?
So they're starting this, part of the Movember PCRA grants is a trial called lutectomy, and it's about giving it before radical prostatectomy, and then they're going to do the radical prostatectomy, and they're going to take that prostate out in those men who are involved, and they're going to look to see how much is left. But at a physical level, using lutetium's got a 1.5 millimetre wavelength. That means that when you go down below 1 millimetre, your dose reduces. So my personal feeling is that I don't think it will ever replace external beam radiotherapy or radical prostatectomy for treatment of the initial disease.
My brother's had 4 cycles now of lutetium, 12 or 13 months before PSA started to rise. He's had another two injections after that. It's still very constant now. That's 10 or 12 months later. But he has severe saliva gland troubles. Would you like to comment on, because I noticed in America, while Cornell have got a cutting down on saliva gland damage via their protocol.
Yeah, so we've been measuring everyone. So mild, usually mild dry mouth. If you have more than 6 doses, people get moderate dry mouth. So it depends on the number of doses that you have. They're actually coming out with some blockers, so some salivary gland blockers. I don't think reducing dose for salivary gland is the way to go. You'll actually reduce efficacy. So I believe that we need to, in fact, the receptors in the salivary gland look a bit different to the ones on the cancer cells. They've got a different, and I saw an abstract, came out about 4 months ago, where they've actually been able to block the salivary glands and the kidneys and not block the cancer. For me, that's the way to go. I don't like the way that other people are reducing dose. You reduce dose, you reduce effect, you reduce time alive.
And as someone with a head and neck cancer who's had a lot of radiation to the mouth and knows about some of the damage to teeth of dry mouth, your brother needs to see the dentist, and there are products by a company called Biotene that can really help you because it's an unpleasant thing. She's a powerhouse.